Hi there, folks. Welcome to today's webinar from Archer Review. Thank you for joining me today. For those of you who don't know me, my name is Hiva Koladrabits. I am a family nurse practitioner here with Archer Review. I'm an instructor and content creator. And today we're going to talk about pediatrics and caring for our pediatric patient population in the primary care setting as a nurse practitioner. So this is one of the topics that I really love to talk about. This is a patient population that I really love to treat. So it's very near and dear to my heart. And I think if you have the privilege of treating these young kiddos, it is really a wonderful thing. So I appreciate your joining me today. If you haven't participated in one of my webinars before, you will get familiar with the setting. I like to keep it pretty interactive. It's just going to be us today. I don't have a chat support, so I will do my best on the chat. But what I really like to do is throw in a lot of practice questions for you guys. And I've been using this awesome tool called Slido. And this is a really nice way for me to interact with you guys so that it feels more like a classroom setting as opposed to just a virtual setting. If you haven't used Slido before, it is anonymous. It's a really fun tool to answer the questions that we're going to present to you today, and then see what everybody else is saying as well without having to worry about putting your name out there. It's completely anonymous when you participate. So it's a fun way to interact and also allow yourself to make mistakes and see what your peers are saying as well. So we'll be doing a lot of Q-Bank questions through our Slido tool, and we'll also be doing a case study at the end of this webinar as well, just to help solidify a lot of these concepts for you. If you haven't used Slido, you're going to go ahead and scan this QR code, and I'm going to do this with you guys today as well, just to make sure that we're all comfortable using Slido. So you can use your phone to scan that QR code. If you're watching this webinar on your phone, you can go to slido.com and put in the hashtag PEDS for NPs, and it'll take you to this Slido. So you just want to hit join Slido and you'll be there ready to participate. So I like to warm us up on Slido and launch our first poll, which is, where are you joining from? And this is just a free text you can just put in wherever you're from. And I always like to start off by doing something fun and interactive like that so that everybody kind of knows who is in the audience and where we're from. And you can put in your city, your state, your country. Typically, we get people from all over the world as well. So I'll put Plano in here. That's where I'm from, and that's where I'm speaking to you from today. So seeing some folks from Plano, Texas, that's me, and then also from Michigan. So welcome, welcome. We're going to launch the next Slido just to get you guys really comfortable with the tool. And so that's going to be who's in the audience today. Again, this is something where you can kind of free text and say, are you a nurse? Are you a nurse practitioner student? Are you a FNP? Are you getting ready to sit for your boards? You can tell me a little bit about yourself today, get a little bit of those jitters out. So I see some NP students, RN, not sure what FI stands for. Maybe somebody from Florida is putting in the free text where they're joining from. So I appreciate that. It's always nice to see where people are joining from and where you are in your studies. So I see a family nurse practitioner in the audience. That's great. I see a nurse practitioner student, an RN, and you guys can also put in there how far along you are in your academic career. So are you just starting off in NP school? Are you getting ready to sit for your boards and wrapping up? Are you getting ready to sit for your clinicals? A lot of people have Archer supporting them all the way through their nursing career. So it's not just getting ready for your boards exam. So I see some people are in their last year. That's exciting. And I see somebody else has joined us from the Philippines. So yeah, we get people globally as well, which is really nice. And that's fine. You can put that free text in here as well. well too. I know that was our last one, but this is really just a warm up to Slido to make sure everyone's comfortable with using it. So feel free to put those in there. And then somebody else is going to be done in August. Very, very exciting, you guys. And so then I like to put another warm up in here. And how are we feeling about New Year's resolutions? And if you know me, you know I love my emojis on a scale of really sad emoji to really happy emoji. Now we're getting well into the end of January, and I'm not one for making New Year's resolutions, but I definitely did this year. So I think it's always fun to see if people are still sticking to their New Year's resolutions or if they're kind of giving up. So I see one kind of smiley face in there. Let's see if we have any other responses. And some, I'm going to put mine in there. So I'm pretty happy with my New Year's resolution so far. We see some people mostly still sticking it out with the New Year's resolution. I like it. And then I like to see what people make for their New Year's resolution. So typically our students, a lot of students say they want to pass their boards. That's their big New Year's resolution for 2025. But what is your New Year's resolution? You can put in multiple responses as well. And I'm going to put mine in here too. We're going to do more exercise is what I've been going for, just because it gets harder and harder as you get deeper into your career and have little ones and just life, right? So, and I know you guys feel that as nurses and nurse practitioner students, but what are some of your New Year's resolutions if you have any, or maybe we can make one together today? All right, but it looks like, yes, pass my nurse practitioner exam. That's a big one, and I see that a lot. Yeah, very good. Hopefully we can help you get there. But what I like to emphasize in my lectures is we're not just studying for the exam, but my goal is really to help you care for these patient populations as we are entering clinical practice so I can help you be a safe and effective clinician. That is my biggest goal. Once you are really knowing the material and not just memorizing it, you will be fine for your exams. That's just an added bonus to show that you are a safe and effective provider, right? But my purpose is hopefully to help you walk away with something today that you can bring to your clinical practice. So let's get started. I think everyone's pretty comfortable with Slido. That's the tool we're going to be using throughout our presentation today as I'm pulling in some of those questions from our question bank to help solidify some of these concepts, like I said, in that case study at the end of our webinar today. I always like to start off our pediatric lecture with milestones. And so what are milestones? And some people get a little bit tripped up over milestones versus screening. But remember, pediatric milestones are the skills or abilities a child hits at different stages of growth and development. And these are the milestones that we really observe for and monitor to make sure that that child is reaching normal growth and development in adulthood. The way I like to say it is, and I heard this used once and I really liked it, the concept is if you were to schedule a trip of driving across the country, say you wanted to drive from California to Massachusetts, you most likely would map out your way and have a couple of checkpoints where places you might be staying for the night and taking a break, maybe some sightseeing. You have some checkpoints along the way to make sure you're getting from point A to point B. That's essentially what milestones are for our pediatric patient population. It's our ability to make sure that our kiddos are hitting certain milestones to get them to a healthy growth and development in adulthood, right? Now, with milestones, you have your average. So 1 to 2 months, you'll probably see some social smiling, the baby's getting more alert and starting to observe others, holding their head up during tummy time. But the most important thing is to remember that these milestones are an average. So you have some kiddos behind the average and some kiddos ahead of the average. And all that is within normal, right? So as clinicians, we have to be really astute. We have to do a really good job of looking at the big picture and looking at what milestones are we missing and helping identify gaps. Because with that same concept of that road trip across the country from California to Boston, you don't want a kid getting kind of stuck in Colorado and just going around in loops, right? You want want to get them eventually to their destination. So if we're noticing gaps in these milestones, that's when we should have our red flags up and say, hey, this is where we need to intervene and help this child along. Right. And so anytime we do something with repetition, it's really so that we can catch it early and intervene early. So that's what's going to be really important with these milestones as we're going through. You probably have plenty of charts and graphs from school that you can memorize, but as you're going through it, I want you to be thinking about that concept, trying to identify the global picture, identify those gaps, and that's when you're going to know when there's need for intervention. Now, the other clinical pearl that I have with milestones is if you have not had the pediatric experience, if you've not been a pediatric nurse, if you've not had kids of your own, you probably have to do a lot more memorizing of these milestones and these tables and charts, right? The best thing to do is to really visualize that child in front of you. So when we're looking at an exam question or when we have a 2 to 4 month old in our office, we want to be really picturing what that 2 to 4 month old is capable of doing in terms of milestones, right? So when you're sitting there on exam day, I want you to also be visualizing that child. So when you're studying, looking at those charts, try to really visualize that child and pull from your clinical experience, pull from your personal experience to visualize that average 2 to 4 month old. But in this phase, we really want to be doing a lot of educating parents, making sure we're getting those neck muscles really strong, right? So talking to those parents about doing a lot of tummy time. Of course, it's going to be in short spurts, but doing them often and always observed is going to be really beneficial. The kiddos don't like it, but getting them on the floor, get down on the floor with the kids and make sure we're strengthening that head and neck control so that that helps also reduce the risk of SIDS for these kids, right? So a lot of teaching and education goes into what we do as clinicians for the parents. Now, again, by 6 months, you might see some kiddos rolling from front to back. Maybe some of them are starting to sit up and really start to recognize those familiar faces. And then between 4 to 6 months, we're going to be talking about starting solids, and that's going to be really on a case-by-case scenario. I'll tell you a story once we get to a little bit further into this lecture about growth and development and identifying failure to thrive and my personal story with starting solids with my kiddos, which were both very different. All right, so moving on with milestones by 9 months, really we're starting to see majority, the average child is starting to crawl, maybe say mama, dada, waving. We're going to also be working on that pincer grasp, so giving them plenty of opportunity to do that. You know, they make all these fancy different types of Cheerios-like things, but even simple plain Cheerios, not honey nut, but the plain ones are really good to help that kiddo just practice that pincer grasp. That's really good. By 18 months, they're really moving and grooving. They get very active. Some of them may be running. We also see big explosion in words, right? We're looking for that cognitive development. So about 50 words on average, giving them plenty of opportunity to scribble on paper. Again, that's helping with that fine motor control. And then they might also be able to follow simple instructions. By 2 to 3 years, we're really getting into those preschool years. And again, we see a huge explosion in words of on average 200 words. They really become chatterboxes, which is really wonderful to see. And then we also want to be watching for that social interaction and asking those questions, right? This is going to be on average the most common time where we first start to see autism present around age 2. So we really want to know when we have that kiddo in our office, what is this child doing on average during the day? How much interaction are they getting with their peers? And how are they interacting with their peers, right? How is that going? We really want to see what that social interaction is like. Are they making eye contact? Are they making friends? All those things are actually really important. And then they also start to really notice their own feelings and feelings of others. So talking to kids about feelings and identifying feelings goes a long way in helping with their growth and development as well, their social emotional growth. As we go into those preschool years, we see a lot of improvement in those fine motor skills. We see a lot of improvement in those cognitive abilities. Maybe they're learning their letters, their numbers. Again, those social skills, they really are social butterflies. They enjoy that. And then by school age, our milestones become more academic. So again, with these milestones, we're looking for gaps. We're looking for the big picture. Is this kiddo consistently behind average, but meeting those milestones a little bit delayed at each visit? That's okay. Is this kiddo consistently ahead at each visit? That's great, and that's okay. But if we see that is this kiddo consistently not meeting one of those abilities, right? Meeting one of those areas that we measure cognitive ability, we measure social, emotional, fine motor, gross motor skills. So is there one area where they're consistently not meeting those milestones? That should be a red flag. We want to intervene and figure out what's going on. How can we best support this child and help support their growth and development? That's really important. Other red flags, again, remember around the age 2 is where we start to see those first early signs of autism presenting. So are they avoiding eye contact? They're not responding to their name. They're not following those simple instructions. We definitely want to figure out what's going on and intervene early. Awesome, awesome job. So let's see how that might present on a practice question. And I'm going to launch this poll for those of you who read a little bit faster than I do. Let's see, this is poll number 6. So let me launch this for you guys so you can go ahead and answer, and we'll read the slide together. So the nurse practitioner knows that a motor developmental milestone for a 4-year-old child includes what? Is it A, B, C, or D? Riding a tricycle, skipping and hopping proficiently on one foot, or C, performing broad jumps, or D, walking on tiptoes. So again, this might be a way that it might present. They want you to know what are you looking for at that 4-month visit when you're looking at motor development milestones. So the nurse practitioner knows that motor developmental milestone for a 4-month-old child includes what? So go ahead and answer in that Slido for me. Go ahead and activate this poll. And if you lost the Slido link, you can always scan this QR code. You can go into slido.com and you can put in that hashtag PEDS for NPs. All right, so what do you guys think it is? So we have a couple responses. We've got riding a tricycle, skipping and hopping proficiently on one foot. All good guesses. Yeah, and so let's go back to the question. So the right answer is B, skipping and hopping proficiently on one foot. And so it's okay if you got it wrong today. Let's break these down as to why that's the right answer. So remember, a 4-year-old, we're looking at what are we expecting a 4-year-old to have already known how to do and already have reached those milestones. And what is that new milestone that we're looking for at this 4-year well child visit? Skipping and hopping proficiently on one foot, how does that stand out differently from the other ones? If you didn't know what was the right answer, you could kind of break it down and be like, well, riding a tricycle requires 2 feet, right? That child is sitting on a tricycle and pedaling with 2 feet, or maybe doing one of those cruiser bikes with 2 feet. Performing broad jumps, also with 2 feet, right? Walking on tiptoes, also with 2 feet. What is the difference between A, C, and D and B? So A, C, and D are all on 2 feet, and then B, skipping and hopping proficiently on one foot. That's going to require a different type of balance. That's going to require a new milestone with that motor development where that child is really balancing on one foot. So that's going to be the biggest difference. And really, A, C, and D is something we expect by the time the child turns 3. And then by the time the child turns 4, that balancing on one foot is really a big motor skill, motor milestone that we look for and comes around the age 4. So awesome job, you guys. I love that you're trying and participating, and you really learn a lot from these practice questions. So let's shift gears and talk about screening. A lot of people get tripped up over the difference between milestones and screenings. What are the differences between screenings and milestones? Remember, milestones are those skills that we're looking for, those very specific developmental skills or abilities. Screenings are just a way for us to make sure that we're screening at different intervals so that we don't miss those milestones that are lagging behind, right? So we have a lot of different screening tools, and we start with the newborn screening to make sure that these kiddos have the ability to hear. So we do a hearing screening in most states. It is usually state by state, but these are usually the global things that we do across all the states. And you'll have to look at your state when you're practicing to see what happens on the inpatient side, if you're practicing on the outpatient side, so that when they come to you for those newborn visits, you know what's already been done in the hospital and you know what you need to do as well. So we really try to do this pretty early on to make sure that we are supporting this child's development. So in the hospital, that newborn screening phase, we are checking their hearing. We're screening for hearing to make sure this child can hear so they can start hearing sound and mimicking sound with babbling, right? We also do the bilirubin check, so you might have to do that when they get discharged home just to make sure that they're clearing things, they're clearing all that bilirubin. And then we also check for any congenital heart disease. So these are the three main ones that most states do perform. And again, those screenings really start at this newborn phase and we continue to repeat. So again, anytime you have repetition, it's because we want to make sure something is not missed. We catch it early and we intervene early. That's really, really important. So we continue these screenings all the way through. In that first year of life, we have a lot of screenings. We do it at 2 months, 4 months, 6 months, and again at 12 months. And so it's really important just to make sure that we are supporting that newborn through that first year of life and beyond. And what happens at those visits? We start to do a lot of measurements. So we're measuring length, we're measuring weight, we're measuring head circumference. Right around the age of 2, most offices switch out that head circumference for a BMI, and then you get everything on a chart so that you can see if that child is following their curve, their growth curve, right? And we'll talk about that in a few slides. But again, at those visits, you're going to be observing those milestones, you're going to be asking those questions. And then by the age of 1, we typically, again, this is state specific, but we typically do check for any signs of anemia. So we check the hemoglobin hematocrit. And then most states also do a lead screening. Now, I will give you an example. I am practicing and living in the state of Texas. We do not universally do lead screenings in the state of Texas. It really depends on where you live in the state. And so even within our own pediatric practice, we have different locations, and one location may universally do lead screenings because those communities have older homes, and then where another location may not routinely do lead screenings because those homes are newer built. You have to ask the question, you say, where does this child spend the majority of their time? They might live in a community where the homes are newer built, but do they then go to school in a different community where that school was built more, it was not built more recently and it's an older build? Or do they then go to an in-home childcare service where it's an in-home that's an older home as well? For me, I'm always overly cautious with the lead screenings because without lead screenings, you cannot, you have no idea that child has been exposed until those levels are really high, that there's been high exposure. And by then, there's been a lot of damage to the nervous system already, and it can really delay growth and development. So for me, I'm hyper vigilant about making sure I ask the screening questions, and I always err on the side of caution of going ahead and doing the lead screening, both in my practice and for my own kiddos, even though we live in an area where it's not as common. And that might be because of my training and growing up in the Northeast where everything is just older homes, and it really was drilled into my head and my training to do the lead screening and watch out for it, but it's something that I'm hyper vigilant about. So again, you have to ask those questions. All right, so let's go to our next poll, and I'm going to launch it for those of you who read a little bit faster than I do, and you can go ahead and answer. So, how might screenings come up on your board's exams? A 4-year-old child presents to the clinic to establish care. The mother brings copies of all immunization records and the last 2 office visit notes. So, they're establishing care. It's a 4-year-old. They bring all their records with them, including office visit notes and immunization. So, this mom is really well prepared in taking care of her kiddo, right? We can see that she's pretty organized. You can assume that right away. The child was born without complications at 39 weeks, so full term, and had no chronic health issues. So they're telling you that this child has been up to date with their immunizations, born full term, otherwise healthy. The records report typical milestones and development and occasional viral or ear infections, but it's not uncommon for this age group. So they've met their typical milestones and occasionally had some viral infections, ear infections, but otherwise nothing out of the ordinary. What screening is required for this well visit? Is it A, vision, B, lipid testing, C, PKU testing, or D, TB testing? What do you guys think? Give it some thought and answer the poll in Slido. So what is the typical screening that we think would be required in this visit? All right, we've got one response. I've got 2 responses. All right, you guys. Yeah, so the answer is A. Absolutely right. And why is A the right answer? So I kind of broke this down for you as we were talking about it, and you guys absolutely got it right. So vision is going to be what we expect at this wild child visit. Why are the other responses not right? Let's start there. So with the lipid testing, we're most often going to do this in early puberty and if we've got some warning signs, right? So it's not really something we'd be looking for in a 4-year-old who's otherwise healthy with no chronic health issues. With C, PKU testing, this is also something that's done pretty early on, typically as part of that newborn screening. So again, you have to find out what happens in your state. But if this was something that was missed, so PKU is a genetic metabolic disorder. But again, if it's something that didn't happen in early screening, we would start to see some severe intellectual disabilities by now, by the time this child has reached 4. But this exam question's already telling you that this mom's pretty organized. She's gotten all the records in the office visit with you today. Child was born healthy and has met their typical milestones. So we know that that's not the case, right? And then D with TB testing, we don't universally check everyone with TB testing. Again, this is going to be if we think that this child has been at high risk or exposure, either with their living situation or with their traveling history, and none of that was given to us in this exam. So right away, all those we can rule out. And then with vision, with our 4-year-olds, again, with here, this is pretty typical for our 4-year wild child visit because we want to make sure as they're in those preschool years, we're catching those vision issues so that that child can see and learn, right? That's really important. So vision and hearing is again checked at that 4-year well child visit. Awesome, awesome job, you guys. So again, you can really learn a lot from these practice questions and learn a lot from the rationale. You get really detailed rationale when you are practicing these questions. Now, I want to pause for a minute and talk about failure to thrive. What is failure to thrive and why is it important for us to identify as clinicians? So failure to thrive is just when our kiddos are not meeting that normal growth and development, right? And the way we can identify it, the way we can define it is if that child falls below that 5th percentile for weight, according to their age, that's going to be a big red flag. A decrease of 2 or more major percentiles on the growth chart. So typically that head circumference gets preserved last. It's the last to drop. Typically we'll see a drop in weight and height, right? Or length. And so if we see a decrease in 2 or more, that should also be a red flag. Why is this kiddo dropping in their growth curve? Or less than 80% of average weight based on height-weight ratio. So this is really another way, another screening tool for us to be able to make sure that our kiddos are meeting their growth and developmental milestones, right? And so there are a lot of different causes. I've kind of broken them down into 3 main categories. There are a lot of causes within each category, but we want to be identifying the cause, addressing the cause, and getting our kiddos back on track, right? Inadequate caloric intake is a big one, and a lot falls under that category. You can also have malabsorption issues. So is this a chronic GI issue that we're starting to identify, a food allergy, or maybe increased caloric demand? What's going on? Is there a tumor that we need to identify? So we really need to dive deep into these buckets. But our first screening tool is really identifying it on those growth curves. I'll give you my personal story. So with my second kid, he started to fall off that growth curve, and our pediatrician was very astute, did a deep dive, and realized that he was not getting enough calories. He was exclusively being breastfed at the time. At our 4-month check, we saw that drop. We started solids right around 4 months, and he went right back onto that growth curve. It's been fine since. So you really have to figure out what's going on. If we see a drop in that weight, if we see a drop in 2 or more of those categories, again, typically weight and length, what's going on? We need to explore that and make sure we get that kiddo back on track, right? That's going to be really important. And I always like that story because with my first kid, they were pushing really keeping her exclusively breastfed till at least 6 months to avoid food allergies. And then with the second kid, the guidelines had changed. So you really have to, as you stay in clinical practice, keep up to date with the guidelines and just do a little bit digging as to what's going on when you see those red flags on your milestones and your screening and your visits. All right, so again, want to emphasize these warning signs with autism spectrum disorder. We really want to make sure that we're supporting kiddos and giving them the resources that they need. So our main job as primary care clinicians is to really identify and get them over to the care team that's going to help support their growth and development. The biggest red flag is really regression from previously met milestones. That should always be a red flag in your mind. If that child has not really been verbal, they're not meeting those social emotional skills or milestones in those screening tools. If they're lacking the eye contact, they're not really responding to their name, they have a flat facial expression. All of that can really be a sign that this child may need more support. And we're going to go ahead and send them over to our behavioral health specialist, and a psychiatrist will use the DSM-5 criteria to help make the diagnosis and also put out an appropriate plan of therapy. That might be behavioral therapy, exposure therapy, pharmacotherapy, or some combination thereof. All right, you guys. So before we dive into the next part, I know we're going to take a little brain pause for a minute. I know we talked a lot about all the different milestones and screenings, and I pulled in some Q-Bank questions. If you need more support, if you feel like that was all kind of over your head and you need to dive a little bit deeper, I know some of you have, this is your last year, you're getting into those clinical rotations, so it will come. But I wanted to make sure you knew that our Q-Bank has a free trial and you really do learn a lot from those practice questions. We give you the rationale and it's free, so why not try it? I really enjoy pulling those questions into these webinars to show you guys how rich those practice questions can be. And it gives you a readiness predictor. So when you are ready to sit for your boards, you know you can go in confidently that, you know what, I'm going to be fine. If you just need help, you need more support, maybe you're not getting it through your program, maybe you just feel like you need a study buddy. We also have mentoring services. And with our SurePass, you get those, our SurePass Pro, you get those mentoring services thrown into everything else, which is our Q-Bank, our on-demand, and our 3-day live reviews, which are a really nice, robust way to prepare for your clinical rotations and your boards exams. We have a lot of students using it for both. So I wanted to take a little brain pause. You have a QR code if you want to scan it. You also have in that little hamburger in your Slido all the links to our social media page as well as these different packages. So go ahead and take advantage of that, especially some of those free offerings like today's webinar that you're participating in. All right, so keep it going down the content. So I hope that was a nice little break. Let's keep going with the content, and I'm going to keep going with those practice questions. And please feel free to put your comments in the chat for me, and I hope you're enjoying the Slido tool as we're going through. So with vaccines, unfortunately, with vaccines, you do have to do a little bit of memorization. Sometimes, I'm not a big fan of just memorizing things. I like to understand things, but with the vaccinations, you initially have to start memorizing it, and then you'll understand why we're doing certain things at certain intervals, right? So when we're vaccinating a child at a certain interval, it's because we're preparing for an age where they're going to be at most increased risk of developing that disease or contracting that disease, right? So we're going to try to protect them. And one big thing that we've really moved towards is making sure with this hepatitis B vaccine, we are starting that at birth. And you'll see that that's the only vaccine that's really started at birth. But within those first 6 months of life, we're already giving 3 doses of hepatitis B. So as you're studying the vaccine chart in the schedule, you really want to look for the patterns, and you want to be thinking about this is what this child is going to be at most increased risk for as they're developing at this stage, right? That's how you're going to remember it. You also can create a lot of mnemonics like DRIP, DRIP for those 2, 4, 6-month visits. So we're going to do that DTaP, the rotavirus, IPV, and the pneumovax, right? We're also giving the HIB. But mnemonics can go a long way if you don't have that pediatric RN experience where you were giving these vaccines all the time and it kind of becomes second nature. In practice, of course, once you see these kiddos, your nurse is going to pull those vaccines and you're going to know it by heart because you're going to do it so many times. But when you're initially getting started, it is going to be some amount of memorization and practicing those practice questions to help solidify it. So I'll throw a couple of those in today. But you also want to look for patterns like we start to do Tdap around the age of 7 because we don't need as high dose of that pertussis. It's really, we're getting them initially vaccinated early on where they're at most increased risk around ages 6 months to 2 years for pertussis. And then around 7 months, it's really used as a booster. So we switch over to the Tdap. And the way it's sometimes written is that capital P for the DTaP. So there's more pertussis in the DTaP, and then you have that lowercase p on the Tdap because it's less pertussis, and that's the difference there. I also want to point out that we don't start vaccinating our kiddos for varicella and MMR until 12 months, and then we do a booster at 4 to 6 years. And again, when you start to see exam questions like exanthems popping up around ages 4 to 6, you want to be thinking in the back of your mind, did this child get their varicella and MMR if they're exhibiting some of those symptoms of measles, mumps, rubella, varicella? All right, so without further ado, let's go into another practice question, and let me launch this poll for you guys. We're going to go to poll 7, and I'll let you answer it. And we'll read it together. So the nurse practitioner prescribes administration of which vaccine for the term newborn within 24 hours of delivery? What do you think? A, B, C, or D? And I'll give you guys a few minutes to answer this question. But remember, they're telling you this baby is term, and this is within 24 hours of delivery, and they're not giving you any other information, so you can safely assume that everything else has been going well up until this point. So what do you guys think? Yes, awesome job. So we talked a little bit through this already, but that hepatitis B really starts at birth for everyone universally. And then we're not doing measles, mumps, rubella until 12 months of age. HIB, we're going to start at 2 months. IPV, again, 2 months. So this is one way you could potentially see this type of exam question about the vaccines. Let's practice another one. The nurse practitioner knows that infants can start receiving the DTaP vaccine at what age? Is it A, B, C, or D? Let me launch this poll for you guys. What do you guys think it is? So we're talking about the D tap. And you can see that that P is capitalized, but when can this infant start receiving the D tap? Is it at 2 months? Is it at 4 months? 7 years, 11 years? Kind of funny the way it's written. It says infants. So I think you could probably already eliminate some of those answers. Yeah, very nice. And so we're seeing a lot of you saying D tap starts with that drip, right? At that 2 month visit, we're going to give it again at 4 months, but they're asking when can they start receiving it? So we're going to start with D tap at 2 months, and then we're going to do it again at 4 and 6 months. Again, 7 years, we're going to switch that Tdap, and then 11 years, we're really thinking about other vaccines like meningococcal. Awesome. Okay, now let's jump into puberty. This is, some people love studying and learning about puberty, and some people really don't like it. But I think this is a really nice age to really help support our kiddos as they're going through some of these awkward years. And it can sometimes be really hard. So building that trusting relationship with your patients is going to go a long way. What are some ways that we can identify that this child is advancing through puberty at the normal interval? We have these beautiful Tanner stages that help us really identify if our kiddos are meeting this milestone, right? In our females, we look at the breast development as well as the pubic hair and the stages of pubic hair development. We have stages 1 through 5. Stage 1 is that pre-pubescent stage. Really, we're not seeing anything. We're not smelling any body odor. We're going to be asking that question. We're not seeing any pubic hair development or presenting, and we're not also seeing any changes in that breast tissue as well. And then all the way through stage 5, where we're seeing really that full maturation, we're going to see it marks that sexual maturity in adulthood or by the end of puberty. And then in boys, we also have Tanner stages 1 through 5. Again, stage 1 is that pre-pubescent, and then stage 5 is going to be that full maturation or sexual maturity. And what we're looking for in our boys, we're going to be measuring the testicular size. We're looking at that as well as the penile length, as well as the pubic hair growth. And so one fun little poll that I always like to see if people know, and it might be something that pops up on your boards, is what do you think comes first? Do you think that the child will develop more in the testicular area? Do you think they'll have testicular enlargement, or will you see the penile enlargement first? What do you think is first? And so something like this might also be a way that the boards also wants to gauge that what's normal and what's not normal, so that you're not raising red flags with patients and you're reassuring patients. So what do you think develops first as you're studying these Tanner stages? Is it more testicular enlargement or penile enlargement? Which one comes first? And I know this is a tricky one. But absolutely, yes. So we're seeing, you guys absolutely got it right. Testicular development actually happens first. So sometimes you'll see an enlargement in that scrotal size, and you'll see the testicles getting a little bigger, and the kiddos feel a little bit awkward about it, and the parents get really concerned. So that is actually normal. We'll see that testicular enlargement first, and then we'll see the penile enlargement, and that is normal and something you need to reassure your kiddos on. So let's practice how that might present. We'll go to our next practice question, to poll 10. And we'll read it on the slide together because it's a little bit wordy. So a 13-year-old male presents to the clinic for an annual exam. The patient reports his breasts are becoming larger. Upon physical exam, the nurse practitioner noted bilateral breast enlargement, but with no masses. So you're doing a thorough exam and you find no masses, even though you are feeling some breast tissue. Besides the bilateral breast enlargement, the nurse practitioner notes that all systems are within normal limits. Which of the following is the most appropriate intervention? So I've gone ahead and activated that Slido, but let's read through the answer choices together. Choice A, start the patient on testosterone therapy. Choice B, prescribe an estrogen blocker. C, refer the patient to a pediatric endocrinologist. Or D, notify the patient that breast enlargement is a normal finding at this age. What do you guys think? Is it A, B, C, or D? I know this one can be really tricky, and this is a really common one that comes in, especially as our boys are going through puberty. They get really self-conscious about their body. They start comparing themselves to their peers, both in our females and males. So you really have to get comfortable with what's normal, what's not normal, so we know when to reassure and when to raise our red flags. So I'm seeing a lot of you are answering choice D, notify the patient that breast enlargement is a normal finding at this stage. That's absolutely correct. You guys got it on the nose. So let's talk about why the other ones are not right, and we'll come back to D. So A, it says start the patient on testosterone therapy. Can that make gynecomastia worse sometimes? Absolutely, yeah. So you absolutely don't want to be starting this patient on testosterone therapy. That is not the right choice. B, prescribe an estrogen blocker. Is that something that's going to help this patient, or could it potentially hurt or harm this patient? Absolutely. Yeah, it could potentially harm this patient. So this is not an FDA approved treatment for gynecomastia and not something that you would be prescribing in your outpatient practice. What about C? C, refer the patient to a pediatric endocrinologist. What do we think about that one? Was that kind of like a maybe? We're stuck between C and D. It's funny, we do see a lot of referrals to pediatric endocrinology, and that's because a lot of patients who get very anxious about this, their parents are also getting really anxious about this, and it's coming a lot. The message is coming from home that maybe something is wrong. So the family just gets really anxious, and they do want to see the specialist to check all the hormone levels and make sure everything's right. But that's not really a useful resource in this situation because this is a normal finding. But in some scenarios, we do see clinicians sending patients over to pediatric endocrinology because they're just so anxious about it. But you want to do your due diligence in primary care and reassure this family. Make sure they understand that gynecomastia is a normal part of puberty. It's transient. It could be bilateral, meaning in both breasts, or unilateral, just in one breast. And we do see that breast tissue enlargement. Typically, without treatment, it does resolve within 6 months to 2 years. And we do see it typically developing between the ages of 10 to 12 years old. It's more common in the early stages as our young kiddos are really going through those Tanner stage 2, Tanner stage 3. So again, this is completely normal. You want to be reassuring your patients, but sometimes you might see that they're just so anxious about it. And so the referral might happen, but best practice, really reassure those patients and try to help them understand what their body is going through this very difficult time for them and be understanding of that. Awesome job, you guys. So precocious puberty, what is precocious puberty? That's when we're seeing those early secondary sex characteristics. And so what is early secondary sex characteristics? Sometimes we just might notice some body odor or a couple fine hairs in that pubic area. And if we notice that in females less than 8 years old, remember 8 is still normal. So knowing what's normal and what's abnormal. So 8 is still normal, but if we start seeing it in a 7-year-old, that should be a red flag and we absolutely want to investigate that. If we see it in our boys less than 9, again, 9 years old is normal. If we see it less than 9 years old, that's a red flag. We really want to do our due diligence, figure out what's happening and figure out what's the underlying cause. Could this be a genetic condition? Is it a hormonal issue? Most likely you're going to be sending this patient off to a pediatric endocrinologist to be doing the workup. They're going to be doing their physical exam and looking for signs of those genetic conditions. They might order a bone age and some hormonal levels, some blood work just to figure out what's going on, and then they will treat the underlying cause. Now, how might that pop up on an exam question? Let's practice that. How should you be expected to address this as a primary care clinician? So let's read this question together. Which of the following children exhibits precocious puberty? So our job as primary care clinicians is to be able to flag it and get them over to the right specialist. Is it A, 10-year-old boy with enlarging testicles and pubic hair? Is it B, 10-year-old girl with menarche? C, 7-year-old girl with sparse pubic hair on exam? Or D, 6-year-old boy with 2-centimeter testicles? What do you guys think? What would be a red flag, a warning sign that this child exhibits some signs of precocious puberty? They're developing a little too early. What are we worried about in this scenario? What do you guys think? Yep. Very good. You guys got it on the nose. So that 7-year-old with that sparse pubic hair, I would definitely send them over to our pediatric endocrinology specialist to figure out what's going on. I would ask more questions as she developed body odor, do a breast exam. Let's talk about what her exposures are at home. Our mom, dad, grandma, grandpa, are they using any kinds of gels or rubs, right, for their hormonal therapy? Maybe this is getting on our kiddo. But we definitely want to be thinking this is a little too early. Let's send her over to the specialist to make sure we're not missing anything. All the other ones are normal. So 10-year-old boy with that enlarged testicles and pubic hair, 10-year-old girl with menarche, 6-year-old boy with the 2-centimeter testicles, those are all normal. Very good. And last but not least, our delayed puberty. So we're not seeing those sexual characteristics or sex characteristics until after the age of 13. Remember, 13 is still normal for our females, just a little bit on the slower side. Males after the age of 14, again, 14 is still normal, but on the slower side. But if we're seeing it after these ages, definitely a red flag. We want to figure out what's going on. Is it a nutritional deficiency? Is it a genetic condition? We want to send them over to the specialist to be able to identify some of those physical characteristics and then do further testing to figure out what are we missing here and how can we best support this child and do we need to get them on treatment? How might that pop up on a board's question? So let's go to our next one and read it together. What chromosomal abnormalities are known to cause a delay in puberty? It's a select all that apply. Remember, if you're taking your ANCC, you're going to get a lot of different test type questions, including select all that apply. They'll tell you how many answers are right. So I'll tell you that 2 are right on this today. Even if you're not taking your ANCC, it's always nice to practice these types of questions too, because again, you learn a lot from these questions. So you can go ahead and select 2 answers and put them in the poll for me. What do you guys think? What is known to cause that delay in puberty? What are some genetic conditions that we're thinking about top of mind? Yeah, absolutely. So Turner syndrome and Klinefelter syndrome, absolutely the top 2 I'd be thinking about if we're seeing the delayed in puberty. Turner's most likely in our girls and then Klinefelter's in our boys. So absolutely. All right, you guys. So before we jump into our last case study of the day, of the morning, I want to remind you of what we talked about today. So we pulled a lot of these questions or all of them from our question bank. So if you liked it, you can go and try that free trial. We also have on-demand videos. So if you need something just a little bit more robust that goes deep in, we have over 16 hours of content, in-depth coverage, and it's broken down into little bite sizes so you can navigate to what you want, just talking about puberty, just talking about milestones, wherever you want to learn more of. And then our SurePass Pro or our SurePass groups them both in along with our live review. We have another live review coming up at the end of February. And these are 3 days, Friday through Sunday, where we go in depth, A to Z, cover everything you need to know on all the body systems. And you have access to our instructors and our content creators live. And so it's a really nice opportunity to engage with us and ask your questions and also learn a lot going into not only your clinical rotations, but sitting for your boards exams. It's really designed for getting you prepped and ready for your boards, but we see a lot of students using it for their clinical rotations as well as their boards. But with our SurePass Pro and our SurePass, you get all those recordings. It comes with the package. So even if you can't attend live, you'll get the recordings and you can watch it on your own time. But I really like the SurePass Pro because it throws in one session of mentoring and tutoring. So you can meet with one of us, whoever meets your schedule needs, and see what support that we can provide for you, whether it's going through your clinical, whether it's going through your schooling, your NP school process, or sitting for your boards or entering into clinical practice. I think having someone in your corner is going to help you go a long way in your career. But all these go under our SurePass, and SurePass Pro have that pass guarantee. So it's really a nice, affordable, effective resource, especially since I've been there and it can be really expensive coming out of NP school and getting ready to sit for your boards and then try to negotiate that first job. So really having someone in your corner to help you navigate all that is going to be really effective. Hopefully you're already on our social, but if you're not, make sure you're checking out our Facebook page where all of these webinars that are free to you, again, free content, so take advantage of that, gets posted onto our Facebook group and you can scan that QR code and join us there. You also can follow us on Instagram. I'll be going live a little bit later this morning just to do some more practice questions with the audience, but it's a nice way to also engage with us and see what kind of things are coming up ahead, whether it's with our webinars or with our live reviews. And we do a lot of fun giveaways as well. And lastly, if you have any questions, you can always reach out to us at nursepractitioner@archerreview.com. Okay. With a few minutes left in this morning, because I'm mindful of the time and I'm respectful of your time, I want to make sure we get this case study done before it reaches the top of the hour. So let's meet Sarah. She's a 12-year-old female. She comes into the office with both her parents. She lives with both of her parents. She's otherwise growing well. She's at her 30th percentile in height and 50th percentile in weight, generally looking well nourished, no acute distress. Comes in and her chief complaint is mild back pain. A little bit more about Sarah's medical history. You've noticed a recent growth spurt in the last 6 months, and she started menarche 2 months ago. In her past medical history, she's had no significant illnesses or injuries, and she's up to date with all her immunizations, and she's been meeting her milestones. A little family history, because you're an astute clinician and you've gathered that. You know that her father was diagnosed with mild scoliosis as a teenager, but no treatment was required. Her mom, otherwise healthy, and her history is unremarkable. So what are we thinking? And I'm going to launch a poll where you guys can just answer open-ended, but what are we initially thinking for Sarah? Is she doing well? Are we worried about certain things? What are we worried about? What's coming top of mind to us? Is there a couple of diagnoses that are popping up? Do we need to be asking more questions about her back pain? What do we think is happening with our friend Sarah here? You can go ahead and put just open-ended dialogue in there for me. But what do you guys think is happening with our friend Sarah? Yeah, absolutely. So we're thinking right off the bat, we need to be asking more information, but maybe with that family history of scoliosis and maybe with her back pain, we want to make sure that we're not missing that, right? Especially as she's recently hit a growth spurt, which can exacerbate or worsen those curvatures in the spine. Very nice. So absolutely, you guys are going to gather more history. Remember your old cart. You're going to ask her more about the back pain, and you're going to ask her more about when did it start and how has it been progressing. Turns out she tells you the school nurse recently identified a possible spinal curvature during the routine scoliosis screening. She forgot to tell mom and dad. The slip didn't go home. She forgot to tell you guys. You're now asking about it and talking about it in the visit. Her pain, she describes it as starting a few months ago. It's located in the lower back bilaterally. It comes and goes, so it's intermittent. It's aggravated by prolonged sitting or standing. And then you've done your screening to make sure there's no nerve issue, so no weakness, no numbness, no limitation in her daily activity, no incontinence. So what are we thinking now? Is scoliosis still at the top of our mind? What do we think, you guys? Yeah, scoliosis check. Very good. So we're thinking this is probably scoliosis. We definitely want to make sure we're checking. So we're going to do a physical exam for her. And what is that going to entail? So we're going to be looking at her posture and gait. We see that when she's standing with both arms at her side, we're noticing the unevenness in her shoulder heights. That right is higher than her left. That scapula, that right scapula is prominent, so it's protruding and sticking out a little bit more. And then we have her do the Adams forward bend test. And what is that? That's when she puts her hands together and touches her toes, leaning down, and you're going to be looking from the back, and you notice that that right side is going to be more prominent or elevated in that thoracic region. You're also going to do a neurologic exam. Everything looks good with her reflexes, her strength, her sensation, her balance, no leg length discrepancies. So that's what these little assessments are here that we just talked about. So we looked at her shoulder, her scapula, and the Adams test. And we really see that there is a difference in that curvature, right? So what do we want to do next? What are we thinking for her? And you guys can go ahead and put it in that Slido, but what are we thinking we need to do for Sarah? Absolutely. So we definitely want to get an x-ray, get imaging, and figure out what's going on. Is there a curvature that we need to address and get her over to our orthopedic specialist? Remember, with the referral, you always want to schedule follow-up with your patients. You don't want them to go into that referral bank and then get lost. You want to make sure that you're giving them some anticipatory guidance of what that's going to look like. The orthopedic specialist is likely going to measure the degree of curvature and determine if intervention is needed or if they need to just monitor it. So giving the patient and the parents some of that anticipation is also really important. And then getting them started with physical therapy, really helping them with that core strength exercise to help alleviate some of that back pain for her is going to be really important. And talking to her about pain management and making sure that she's not avoiding physical activity, but she's avoiding or reducing the prolonged inactivity and really managing her pain so that we can keep her young and healthy and active. That's going to go a long way. All right. Awesome job, you guys. Right on time at the top of the hour. Thank you so much for joining me today. I hope you got something out of this lecture that can not only help you with your clinical practice and your boards exam, but help you really meet and enrich the lives of the pediatric patients that you're going to be caring for. It's really a wonderful thing to see. If you're still going to be with me today, I'm going to launch one more Slido and see how you liked it today. So how do we enjoy using our Slido on a scale of 1 to 10? Was it good? Was it interactive? Would you like it a little differently, and how so? So go ahead and let us know what you think. If you need to hop off, that's okay. I'm seeing most people are enjoying Slido, and then I'm going to leave a nice word cloud up for you too. And what topics would you like to see more of in these free weekly webinars? And so that's really an opportunity for you guys to tell us what you need more of, and we'd be happy to provide that for you. Here at Archer, we're really here to support you as the whole nurse through your nursing journey. So thank you again for joining me today. Again, if you need to hop off, that's okay. And I look forward to seeing you in our next webinar.